I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Dr. Sammy, Sinno, Amanda Silva, and Raj Sawh-Martinez. Enjoy.
Hello, and welcome to the May edition of the PRS Journal Club. This is Raj Sawh-Martinez, and I'm joined by my fellow resident ambassadors, Amanda Silva and Sammy, Sinno. This month, our special guest moderator is Dr. Heather Furnas. She's a Stanford undergraduate alum, attended UCLA Medical School, and returned to Stanford for her plastic surgery residency. After training, she, for some unknown reason, skipped over Yale and went and joined the Harvard plastic surgery faculty. Eventually, she did see the light and returned to the Bay Area in California. She currently runs a busy plastic surgery practice, co-owns Allegro Med Spa, and is an adjunct assistant professor of plastic surgery at Stanford. It's a privilege to have you join us today and moderate our journal club, Dr. Furnas.
Well, thank you very much, Raj. It's a pleasure to be on. I am truly honored.
Great. So we'll get right into it. In this section, we'll be discussing a study by Rios-Diaz and colleagues out of the Brigham Hospital in Boston entitled Inequalities in Specialist Hand Surgeon Distribution Across the United States. The authors sought to describe the geographical distribution of surgeons with a subspecialty certificate in surgery of the hand, as well as evaluate the associated factors of this distribution. They used the ABMS, the American Board of Medical Specialties, database and literature mixed with U.S. Census data, national inpatient databases to determine the relationship between training, surgeon availability, and potential population needs. They identified that there were just over 2,000 hand surgeons across the U.S. 70% of those came from orthopedic surgery, 18% from plastic surgery, and the remainder from general surgery, with differential distributions per state. They noted that there was a national density of hand surgeons to be about 0.64 hand surgeons per 100,000 population, and a trauma density of about 46.8 admissions per 100,000 of the population, again, nationally. There was noted to be significant variability between states, and for both those numbers, they noted that the top 5 states almost equaled the bottom, or more than doubled, the bottom 5 density populations when you looked at states specifically. They also found that this variability was associated with the median per capita income and the density of fellowships in each area. I think this study overall marks really key data that's presented in a very thorough and very well-designed study, and I think it will really directly impact the future development of hand surgery programs, where the needs are, where fellowships are created and placed. And I think it's given us a lot of information, food for thought about the current national state and potential disparities that exist. Obviously, this data, when you're looking at it in such large populations with mixed sort of groupings, some of the years in which the data was accessed is a little bit off, so the congruency could be called into question. However, I think it's the best data that's available and really points a really interesting picture of how we've distributed our hand surgery programs and hand surgeons in relation directly to the patient needs given all the admissions data. Dr. Furnas, we'd open it up to you and see if you had any thoughts and what you took from this paper.
Well, I love the paper. I think it's a great springboard. I think that there are a few things that could be studied in future studies to really figure out, do we need more hand fellowships? Do we need more hand surgeons to be distributed more evenly across the states? Or is that impractical? They didn't look at population density. They looked at number of hand surgeons per 100,000 people. So if you look at, say, New Jersey or Delaware, it's going to be different from Wyoming or Alaska. And does it really make sense to have fellowships scattered evenly across the states as far as cost? They also didn't look at the number of hand trauma cases per month because that's a limit of the study, but that might be useful information to see if there's a small hospital that sees hand trauma, would they be able to support a hand specialist surgeon? The other way of looking at it is they did say that the distance between patient and hand surgeon does impact the care that patient gets the greater the distance. So rather than having the hand surgeon go to the patient, maybe if we do a cost analysis, it would be the reverse, bring the patient to the hand surgeon by training the faculty at various hospitals to recognize serious hand injuries, to be able to transport those patients, maybe have telemedicine consultations with a hand specialist. So there are a lot of things that are just out there to be explored, and it's a very exciting paper for that reason.
Yeah, and I totally agree. And actually, two of those points, to be quite frank, I hadn't really thought about much, but I think it's a great point. I mean, the timing distribution, I know in the Northeast we have a huge summer bump for head and face trauma, and certainly hand trauma. Hand probably is a little bit more even, at least in our experience here throughout the year, but the summer gets extremely busy. And then the winters you have the snowblower accident, and then sort of the fall and spring a little bit milder. At least that's totally anecdotal. I really wonder if that distribution in some of the states that had the greater disparities could be looked at, so that maybe you can fly in or have programs where you offer surgeons from the high density areas and maybe have them be at least available or on a part-time ad hoc basis for those timing instances. That's a really great point.
Yeah, they say in one sentence in the introduction, one cross-sectional survey found that 80% of ED directors reported inadequate hand surgery coverage at their institution. So that's a high percentage that indicates that it's probably not just the low-income areas, but maybe something pervasive. And the very first sentence of the article is the lack of specialty emergency care across hospitals in the United States is increasingly recognized as a major healthcare problem. So I think the authors are onto something. They're just at the tip of the iceberg. And basically specialty call coverage is probably an issue across the nation, multiple income levels.
It's funny, and I don't know if you guys caught this. Sorry, just one quick thing is that the sentence right after the one you referenced, and I find this extremely interesting, that in Tennessee, it seems like they're trying to stimulate to have hand specialists by mandating that level 1 trauma centers always have a specialist available out of hours, that only 25% of them actually fulfilled that. So I thought that was really interesting. Sorry, Amanda, go ahead.
Yeah, I mean, that's exactly kind of what I was going to touch on, is the fact that this is an interesting study to look at the density of hand surgeons that are available, but something that they mention in the paper and something that's of further interest is these hand surgeons, are they doing elective hand, or are they on call for the ER? Even if you're a hand surgeon, it doesn't mean you're necessarily covering the ER call in, the city that you're living in. So I think that would be an interesting area to look into as well.
Well, I think you have to have enthusiastic hand surgeons that are willing to take that call. Like, I know you have a new hand surgeon at your program that's very eager to, very interested and eager to do a lot of replants and a lot of complex cases. But I think that's the issue. What do you see as some potential solutions, Dr. Furnas, for maybe incentivizing or lighting a fire under hand surgeons to maybe help overcome some of these disparities with a willingness to take hand call in these traumatic settings?
Well, that's a great question. They did say that monetary incentives did not make a dramatic difference in the call, provision of call. And the question is, was it just that the monetary incentive was not high enough, or are doctors looking at lifestyle, work-life balance, or are the hospitals that need call in areas where there are very few surgeons and there's only so much call you can take? So I think there really needs to be a lot more investigation looking at the cost of providing full care, because it's not just a hand surgeon. You've got physical therapy, occupational therapy, the operating room. And so I think if you look at the practicality of just having more hand specialists among more hospitals, or, as we discussed before, having major specialty centers, sort of the way Kaiser does in Northern California. The neurosurgery is done in Redwood City, and cardiac surgery is done in San Francisco. They have many hospitals around the area, but if you have a specialty concern, you go to that one hospital.
No, one thing I just wanted to touch on, I think that's a great point. I guess there's two things that sort of came to mind. One, I wonder if the data for other subspecialty needs, you think microsurgery, you think complex craniofacial surgery, those are both also, I would imagine, would have similar distributions. In craniofacial surgery, certainly there are specialty distributions, and some argue that there may be too many, and maybe those need to be cut down. I know Sammy, Dr. Rodriguez talks about, with face transplantation, those potentially should be limited to specialty centers for similar, obviously much more complex issues.
Right.
So I wonder if other subspecialty type procedures will, one, have a similar distribution to what's presented here, and two, are we going now with sort of managed or bundled care packages going to see that happening more to really reduce costs? And then thirdly, I think there's an issue or something that's special with hand surgery. The population groupings of surgeons come from orthopedic, plastic surgery, and hand surgery, and general surgery. And in this, I was surprised, but I thought the numbers were a little bit different. I didn't realize 70% of hand surgeons all come from orthopedic surgery. So I wonder if there's an impact from that background, if the orthopods are maybe having, an undue impact there in this distribution, if it would be different otherwise.
That's an interesting point, because when we arrived in Sonoma County, my husband, plastic surgeon Paco Canales, was the only surgeon in the county with a hand certificate, and yet there was a prejudice against plastic surgeons doing hand surgery in our county. And so the primary care docs would refer to the orthopedic surgeons, who would then ask my husband to assist and actually do the case. But the word never got out that he was trained to do hand, and the ER just said categorically, plastics do not do hand. So there may be just sort of cultural a cultural impact as well.
Yeah. That's funny you say that. Just the other day we did a distal radius fracture, and the anesthesiologist was surprised at plastics does.
What the heck are you doing? So what would you guys say, maybe Raj, what is your 20-second takeaway from this paper?
Yeah, no, it's a great point. I think that there's a growing need to study the distribution of our subspecialties in a greater, in-depth manner so that we can really meet the true demand that's out there. And I think this study looks at the best data that's available to make that determination and give us insights into that. That was sort of my 20 seconds.
Love that. That's excellent. How about you, Sammy?
I think similarly. I think it points out an interesting discrepancy in the way that hand care is probably being delivered, and I think that we need to, address that with the sort of undertone that there's a difference in how people are being trained in hand surgery, and we've seen many articles in the journal about this in the last couple of years. So I think with all of that, plastic surgeons need to maintain a strong commitment to delivering excellent hand care everywhere that it's needed.
Excellent. And Amanda, how about you? What's your 20-second takeaway?
So I think what's interesting from the study is, as I mentioned, that what type of coverage are we offering to the ERs? What type of coverage, specifically for replant? It seems that different states have different requirements for a hospital to be considered a level 1 trauma center. Some say you have to have hand surgeons, some say you don't. And is that are we even compliant with those regulations? So I think studies looking into that would be really interesting.
Excellent.
Great. Well, thank you guys, everyone, so much. Thank you, Dr. Furnas, for leading our discussion. That'll wrap up this section of the Plastic Surgery Journal Club for May of 2016.
Thanks, Raj.